Hi, everybody. This is Gigi from Wellness on Wheels, and thank you for joining us this week for our guest appearance, second guest appearance, Dr. Dominic Rascona, who's an intensivist, critical care physician, as well as a pulmonologist. He's joining us for the second interview today to update us on what he's seeing out in the front lines and giving us some feedback as to his recommendations of what we should be doing and not doing. So thank you, Dr. Dominic, for joining us and tell us a little bit about what's going on in the field today.
Much for having me again. I hope we, to the audience, I'm sorry, we've had some technical difficulties, and I hope this goes through. We only have a few minutes. I'm actually on duty. I have to go back onto duty, but we had left time, but the technical problems. Anyway, yeah, I am a pulmonary intensivist. I see patients at the bedside and also by telemedicine. So I have seen a lot of cases in a number of different venues. And the thing I wanted to emphasize today, I don't know, whether the cases are tapering down for good, or as Dr. Fauci is concerned about, another spike coming in the fall as we, relax all of the social distancing rules. So I really don't know. All I can say is that I'm definitely wearing a mask when I go into stores. Actually, you can't, where I am right now in Baltimore, you can't even go into a store. They won't let you unless you're wearing a mask. And I think that that's prudent. I think that that's a good idea. So I think we have to listen to our leaders who, although, I don't trust them either as far as you could throw them, at least, I think they're continuing to, listen to the experts and come with reasonable consensus rules, but we absolutely cannot just go back to normal right now. We have to do it slowly, because otherwise I fear that we're going to have a big spike, and people are definitely still getting it, and they're definitely still dying from it. It's true that the majority of people who are dying are older, have comorbidities, but it's not everybody. Some young people, some, I'll keep harping back on this poor woman in her 40s who had it, and we thought she was improving, and then suddenly she got worse and died. So I think that we know how to manage the disease a lot better. Frankly, there are a lot of intensive care doctors who are not pulmonary trained, and I think that they were ventilating patients with disadvantageous mechanical ventilator settings in the beginning. And I think that they were causing a lot of what we call ventilator-induced lung injury. I'm not trying to cast aspersions. I'm just saying that the disease is not typical for what, most people are used to seeing. And I think there's a reasonable consensus that a lot of cases were made worse by mechanical ventilation. So I think that what we're doing now is really pushing, and if people can get adequate levels of oxygen, even though it looks like they're struggling, we do not put them on the ventilator unless it absolutely is necessary. They're going to otherwise die like right that minute. Otherwise, we try to keep them off the ventilators. We keep them in the intensive care units. We watch them so that if they deteriorate to the point where they would otherwise die, then we'll put them on the ventilator. But if we can keep them off the ventilator, that's what we're doing.
So what kinds of other kinds of conditions are you seeing as a result of this? I know we've heard neurological conditions, we've heard pediatric issues, inflammatory issues. How does this actually work when the virus gets into your system? What is it actually doing to your body slowly so that you end up having multi-system failure? I mean, what happens when you inhale this virus and it goes into your lungs, and now it's going everywhere? How does that happen?
Yeah, it's a good question. We're just learning about the disease, and we still don't know. The autopsy results that I've seen to be honest, I haven't scoured the literature. I meant to. I promise next time you have me speak, I will have gone through the autopsy data because I'm very interested in it. But my passing understanding of the currently available autopsy data is that it's not showing a lot of what we thought, which is going to be the presence of microthrombi. In other words, small blood clots in the little tiny arterioles, the little arteries that go to all the tissues. So, you know, you've got a big artery coming out of your heart, the aorta, and then it branches off into all these other arteries.
Mm-hmm.
And then by the time it gets down to the tissues, it's called a capillary. And we thought that we were going to see all kinds of little clots in the capillaries and the small arterioles, and we're not, apparently. Now, I don't know if it's, I don't know. You know, maybe it's because of the nature of the deaths of the people who died. I think we'll know once we get, you know, a few hundred autopsies. You know, right now I think there's only like a few dozen. Once a few hundred people have undergone autopsy, I think we'll understand the disease a lot better. But you know, it's a respiratory disease. So it's not like, you know, I mean, on the virus, and they found it, you know, but whether or not it can be transmitted that way is not clear. And I don't know I just don't know the answer to that. We are considering it a respiratory illness. It's transmitted by respiratory droplets. And why some people get it really bad and others don't, I think it has something to do with the inoculum size. So if somebody sneezes in your face, or if somebody's right up close to you and talking without a mask and spewing coronavirus like I'm probably doing right now, you know, I mean, I don't know if I am or not, but I could be. I don't know. You know, some people are asymptomatic carriers and it's in their throat. And when they're talking, it's coming out. So you just don't know. But we know that it's spread that way predominantly. Once it gets into your body, we think that it apparently goes along the the lining cells. So like it gets into the bronchial tubes, and then it kind of, the distal bronchial tubes all the way down deep, and then into the alveolar sacs. And then once the virus goes into the cells there, we think it transmits itself by going to adjacent cells. It does not seem to get into the bloodstream very much, which would be the typical way. You know, the virus will get in and then get into the bloodstream and then go off to the races to all the other organs. It doesn't seem to be doing that. It seems to be more of this, what we call contiguous spread from cell to cell in the various lining tissues. So the lining of the lung tissue and maybe the lining of the intestinal tissue, because some people are presenting with GI symptoms, mm-hmm. diarrhea, nausea, vomiting, and not too much in the way of respiratory symptoms. So that's not good. But, you know, I think they're still probably getting it from the respiratory route. You know, in other words, it's coming into their body through their mouth and nose, and then, you know, it gets down to the opening. You know, you've got an opening to the lungs and an opening to the esophagus that are right next to each other, and there's a little flap that usually prevents, you know, food and stuff from going into your lungs. But it's very, very common for people to aspirate from their esophagus into their lungs, and it's also very common for people to swallow respiratory pathogens. And one of the things that happens normally is that when you inhale a bunch of bacteria or stuff, if it gets caught in your mouth and then you swallow it, then your stomach kills it, you know, because there's acid in the stomach. A lot of people take acid suppressive medication because they have reflux disease, and that could contribute to you know, people getting it in their stomach and stuff like that. But, you know, we're still learning about the disease. And so, you know, whenever you've got an unknown situation like this, I think you have to take it very, very seriously. So
how are you using new treatments? I mean, there's been a lot of new medications that they've been trying out. I know we went through the protocol before, but there's definitely some others that have come up that some pharmaceuticals have been put out for other pulmonary diseases, right?
So, I mean, I'm still a fan of azithromycin and hydroxychloroquine when a person gets admitted to the hospital. I just don't see the risk when the person is hospitalized. But I'm in a minority. I'm not the only person who thinks this, but I am in a minority. Most people are saying, oh, there's no data that it helps. And so that is a change from when we first spoke. Most people, almost nobody is prescribing it as outpatients anymore. Because if there's a risk from hydroxychloroquine, if there's a risk, it is going to be in outpatients who are not being monitored in their heart rhythm. But when you're in the hospital, you've got monitors on anyway. So I really don't see a risk when you're in the hospital. So I got news for you. If I got admitted with this disease, I would take azithromycin and hydroxychloroquine myself. So if the hospital doesn't want to use it and other people don't want to use it, it's fine with that, with me, but I would take it because I think the risk is very low and it might help some small number of people. But in terms of other treatments, yes, we have extraordinarily more useful treatments now that were not widely available a month ago, and that includes much more widely available remdesivir, which is the antiviral drug, much more widely available tocilizumab, which is the anti-IL-6 drug, the recombinant antibody, which is both of these drugs are just marvels of technology. So when people talk about how much they hate the pharmaceutical companies, we wouldn't have these drugs if it wasn't for them. So, I don't get any money from pharmaceutical companies, don't get me wrong, but I still, these are marvels of modern technology that we have these things. And then we have convalescent plasma, which is a really old-fashioned thing. If you ever hear people talk about the expression using horse serum, they used to, horse serum, we used to inject horses, and then the horses would create these antibodies, and then we would, harvest the antibodies and put them through a filter and treat them with Clorox or something, which, which would denature all the other proteins, but we would still wind up having these antibodies. Well, I don't know what it did, actually. I'm going out of my field.
Have you used the plasma on any of your patients?
Well, yes, we have.
Okay.
So, but the point is that, acquiring serum from horses, and then they would do something to it, but people would have huge reactions to it, the horse serum, because yes, it would have good antibodies, but it would also have all these other proteins in there that people would have reactions to. So actually, as I come to think of it now, I don't think they had a method of cleaning up the horse serum, and so that's why it would cause so many reactions. But now we have what's called convalescent plasma, and to be honest, I'd have to look up the chemical method in which they make it, but it's basically just human plasma from people who have had the disease. And then, they spin it down in centrifuge and try to get, mostly the antibodies and give people the antibodies without too many of the other proteins. And so you can inject this into somebody's bloodstream, and if they have virus floating around in their blood, then these antibodies can be helpful. But like I just said before, we think that a lot of the way the virus works is by contiguous spread. So I don't know how antibodies are going to be very helpful towards that. I can't think of a mechanism, because if the virus is inside a cell, and then the way it spreads is by replicating inside that cell and then exploding into the nearby adjacent cell, there's no way for an antibody to get to the virus. These antibodies are limited to the circulatory system. All they can do is bind onto particles that are floating around in the blood. Now, there are other kinds of antibodies, like there's all kinds of antibodies in your respiratory system that can be secreted into mucus, and then that can be helpful, to bind onto viral particles that are in the mucus. So, there are ways that antibodies can be helpful, but I don't know. If you give it to people in their plasma, those antibodies need to get to the effective site where the viral particles are floating around so that they can be helpful. So I don't know. We give it. I don't know if it's helping. I don't think it's hurting anybody to give them convalescent plasma. And so I have kind of a stepwise approach to this. If somebody comes into the hospital, again, personally, I would give them azithromycin and hydroxychloroquine, but a lot of hospitals I work in won't even let me now. they disallow it. So much for, professional, discretion. They don't
So
allow it.
we're having issues
If-
now about hospitals worried about patients not getting to the hospital soon enough. And I think you mentioned, the oxygen rate. There are people who are having heart attacks at home and not
Yes.
having entry to the hospital quick enough. They're afraid to go. I mean, now as a intensivist, I mean, I'm sure you see people through the whole progression from the emergency room on when you're called in. What are some of the things you want people to know and to be warned about so that you're not dealing
Yeah.
with things in a critical fashion by the time they get in?
Right. So I'll let me answer that. And then unfortunately I have to go. I apologize, but I gotta I don't want to be late. I'm like I said, I'm going on duty.
No, you're
Um,
saving lives. You're saving lives.
well, I don't know. We're trying. But so I just want to say, so I have my own personal stepwise thing. I would give hydroxychloroquine and azithromycin to patients who are hospitalized but not in the ICU. If they make it to the ICU, then I would personally give them everything. If they're so sick that they need to wind up in the ICU and they might, they're heading towards, multi-organ system, I would give them the anti-IL-6 drug. I would give them the remdesivir, and I would give them the convalescent plasma if it's available. Honestly, that's what I would do. So, and then I would try to keep them off a ventilator. In terms of the answer to your question, absolutely, that is a major mistake for people to make. Just because there's a pandemic out there doesn't mean that people aren't going to still have strokes, heart attacks, cancer, and other, pneumonias. So, when you read statistics, there's less heart attacks and there's less strokes. That's like lunacy. That's craziness. I guarantee you that they're not. They're just going undetected. And there have been a lot of cases where people died at home, and their deaths are being attributed to COVID because they are may come up positive. But we don't know if COVID killed them. They could die to something else unless you do an autopsy and find out exactly what they died from. They may have had COVID and it just added additional stress to their body, and it caused them to have a heart attack, or it caused them to have a stroke, or caused them to have, mesenteric ischemia or some other damn thing that people, can happen all the time. So, people need to know that if you feel sick, I mean, don't you don't go to the doctor for a hangnail, but if you feel sick, you need to go in. And people who live alone, that's dangerous, especially if they're older and living alone, because one of the problems with this disease is that you can become hypoxemic. In other words, the amount of oxygen in your blood can become quite low, and you won't notice it. And that is an insidious thing. That's like a frog in the proverbial boiling pot of water, where the frog is in the water and it feels comfortable, and then the temperature starts to go up and up and up, and the frog doesn't feel it. Before it knows, it's been parboiled. So with oxygen levels, that can happen too. Your oxygen levels can go down, and you might not even be thinking clearly, and you won't even know that you're not thinking clearly because your oxygen levels are low. And then next thing you know, you're dead. So, I think people who live alone, if people have elderly parents or aunts and uncles, you should check on them. You should call them. If they don't sound right, they should go in. I mean, they can have the disease, and maybe all they need is to be put on oxygen for a few days. Right. Maybe that's all they need is some oxygen, and then they could go home. But that would be my final advice.
Thank you so much for your time. I know you have to go. We really appreciate your time.
Yes, well, I'm sorry for the rush.
No, absolutely. We really appreciate it, Dr. Escona. And next time we will get some more details of maybe some of the autopsy research you've done and enlighten us about
that research I've done. I'm just a frontline, worker bee. But I will. I mean, I know a little bit about it, But I think there's going to be some good autopsy data coming out, reasonably soon.
Well, thank you again. We appreciate it. We can't wait to see you again. Take care.
All right, thanks, Gigi.
Bye.